Welcome to AiArthritis Voices 360. This is the official talk show for the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AiArthritis for short. My name is Tiffany Westridge Robertson. I am the CEO and original founder of the organization, also a person living with AiArthritis diseases, primarily non-radiographic axial spondyloarthritis. And I am very, very excited to bring to you this month's episode of our talk show, which features one of our most popular programs we have at AiArthritis, and that is our Go With Us to Conferences program. In this case, it is EULAR 2024, the European Rheumatology Research Conference, and EULAR is for the European Alliance of Associations for Rheumatology. We are super, super, super excited to bring you some highlights as this month's episode. So as we do every year, twice a year, is we go to the biggest scientific conferences of the year. One is EULAR, and that happens in usually June of each year. And then we also attend the American College of Rheumatology Convergence, which is in November of each year. So stay tuned for ACR 2024 and make sure you sign up to go with us virtually, of course. Can't take everybody in person, but sign up virtually at aiarthritis.org/conferences. So let me tell you a little bit about what Go With Us and the conference, Go With Us to Conferences program is all about, so that I can set you up to listen to some of the clips or watch, depending on how you're participating in our talk show today. This is a program that was created by patients, including myself, and shout out to Deb Constein, who you're going to hear from on this episode, because she was going with us as a person living with rheumatology, rheumatoid arthritis. My goodness, what's happening to my tongue today? Rheumatoid arthritis. And she is also a retired dietitian, and she's a co-founder of this program. So she's been building this with me alongside in 2020. And then since we brought on other staff, they have also been helping develop and build this program. So essentially the initial idea was we are going and learning all of this amazing material, this amazing information, and we need to share it with our community, because it is not just about the research going on. The information we're learning about treatments, about health management, disease management is so relevant to our journeys. The issue is really, these are conferences primarily with the audience being rheumatologists and researchers. Now at EULAR, which is this one, it is a little unique because they actually have a patient track. At ACR, they do not. But either way, it is important we felt for patients to really understand and be able to learn with us. And so we developed this program in order not just to reiterate back what we're learning, but really have conversations, really talk to each other, talk to you, and help you understand how you can relate this to communications with your doctors, to your own disease management journey, because we do learn about pharmaceutical therapies and research and different treatments, which you'll hear a snippet about today. But we also learn about symptom control, and you'll hear a little bit about brain fog and fatigue. So those are the kind of things we're learning. And of course, that's interesting, right? And things that you want to learn as well. So you're going to hear today 3 of the debriefs that we did, 4 of the debriefs, my goodness, that we did from EULAR 2024 from those patient leaders who were going with us. So from myself, you will hear about CAR-T. That is a new therapy that takes our own blood, our own metabolic structure of our own bodies. We take the blood that goes into a lab, it gets mixed up, it comes back infused into your body, and as a result, you are healing yourself. It is a very novel process, and it is happening largely in the lupus community and also in a few other of our diseases. So I will be doing a high-level update on that. And then we'll also have Deb reporting back to you on patient-tailored pain management. Layla is going to be talking about what she learned about brain fog. And then Becky is going to talk about opioids and fatigue. So she's going to be talking about that. So you can see that there's quite a variety. Again, you can learn more and sign up for us to go with us at aiarthritis.org/conferences. And I'm going to turn it over to Ryan, our producer, to piece this together and let you witness a little taste of what happens when you go with us to, in this case, EULAR 2024. First up, we'll start with my debrief, which is on CAR T. And here we go.
Hello, everybody. I'm excited to report on some sessions from EULAR 2024, specifically regarding precision medicine, or the science of taking our unique signatures, molecular signatures from our blood, urine, and zeroing in on things like genetics, DNA, etc. And we've been focusing on this for a few years now at these rheumatology conferences, and how by doing so, we can expedite diagnosis, and we can also match treatments to people depending on what might work better or worse for different subgroups. So an advancement, CAR T, C-A-R-T. You may have heard of it. It's something that's been used in the cancer space for about the last decade, and it has recently moved into the rheumatology space very early. This is not something that you can get in your office, even close to getting in there in the near future. But this is important, and this is why we go and we learn and we see what the potential is out there. So this is very exciting. The CAR T, which is essentially they go in, they pull out, in this case, T cells. So T cells from your body, they put them into a lab, they mix them all up with some other things, they put them back in your body, and then what ends up happening in the studies of, we had one lupus patient, then 6 lupus patients, and what ended up happening is with that one dose, all went into remission. And not just remission, like what we might think of as remission, like low disease activity, like no disease activity, completely off of all medications. And so that happened 3 years ago. We did hear about it, I think last year at one of the conferences, and they gave us an update and said the person is still in remission. And these were not people with mild disease. These are very serious. One needed a kidney transplant. So that just shows you the power of these. It is a one and done, we think, but we don't know. That's also something important to understand with this CAR T therapy. It, of course, can be very expensive. We have no idea. Is it going to last 5 years? Is it going to last 10 years? Is it going to last 50 years? We don't know. And that's part of what's happening in the trials, is trying to figure out as they follow these patients who have had it. So in saying that, I wanted to give you, a very specific, I'm going to go into a patient with lupus and heart and lung disease and treated with this CAR T, with this T cell extraction. Didn't know if it was going to work, but this person was so severe, they thought they would give it a try, even though they were completely depleted of all of their B cells, because they were on rituximab, and that is one of the biologics that really do strip your immune system. But even with that, she grew all of the B cells back and replenished, went into remission in 30 days, 100% remission, no medications. So pretty amazing stuff, don't you think? I wanted to let you know too, it's not just lupus. They're doing these CAR T studies on myositis, scleroderma, also known as systemic sclerosis. There's some debate though. Who's going to get these when they are ready, right? How refractory, or refractory means not responding well to many treatments. So you really are not responding to anything. What's going to determine that? Who's going to get access to these? So there is a really big debate there. The other part of that is what diseases. So we have diseases like rheumatoid arthritis that are, for a lot of patients, can be treated pretty easily. But what about the rest of us? Would we even be in line? We don't have RA, but the point is, who gets it? And so that's really just a big discussion. And then to note, though, any existing damage, of course, can't be repaired. So if you have any type of, things that have happened because of your RA or because of your lupus or Sjogren's or anything, that cannot be undone. But so you do have to consider that as far as remission goes. And then another session that I watched was specific to scleroderma or systemic scleritis. But I do want to point out, just because I'm saying that, don't tune out. Don't say, oh, not my disease. I don't care. You do care. Let me tell you why. Because these studies make the rest, open the doors for the rest of us. So understanding and being educated on the possibilities is something that we all should talk about and learn about. It also ties into when do we get treated. So before they started talking about the CAR T or the precision medicine, in diseases that don't have as many treatments, don't have as many as some of the other diseases, they're having to really start to understand when is the right time to treat. We do know historically, all of our diseases, we have seen a process called treat to target, or working with a rheumatologist to be on a drug after a certain amount of time not working so well, we shift. And that is a treat to target. We know that works. We have seen research presented to us in the last several years showing those who are treated early with the right treatments have better outcomes, actually can achieve a remission. It's an actual word that we're actually seeing, but it always involves that early intervention. So that is obviously something that they're targeting here, but they also need to understand is they're developing treatments that are precise, whether it's CAR T or simply targeting certain molecules or different signatures so that they can see what's working best. They're going back through all of the old research for these clinical trials they specifically were doing Actemra. So they looked through and they said, where are our subgroups? Because back when these studies went on, they weren't considering what might respond better in male or female, what might respond better in a person who has long-term disease versus early disease. And so all of these are subgroups. What subgroup do you fall into? So these are things that they went back and they're looking and seeing, did any of these people in this group respond better or worse? And they did find out that there were some data that showed early intervention helped with the skin outcomes. And it also did matter if they had never been treated before and they were early on, they seemed to respond better to people who had been on treatments and had the disease longer. So that's interesting in itself, because why does it matter if you've been on these treatments before versus not? So something matters, but it's just part of what they're trying to explore and understand. They also were looking for what they call predictive markers. So this is something we've been working on in RA, Sjogren's. Oh my gosh, so much in Sjogren's. And I know we're reporting back on that as well. But psoriatic arthritis, spondyloarthritis, there are these predictive markers that they're starting to figure out one biologic works better than others. And wow, wouldn't that be amazing if you could just know, hey, this is going to work for me. So that is all in the process right now. And so they are starting to follow patients in different trials to figure out these subgroups and who might be responding better than others. Let me see. I'm looking at my notes here. And there's another one, and it did talk about the CAR T specific in these patients with scleroderma or systemic scleritis. And they treated 7 patients. So now we've got enough. These are small studies. So they're starting very small and eventually they'll get bigger. And we had 100% in the ones that I just reported back. In this one, it was 7 patients during the 3 months after they received this infusion of the CAR T therapy. Over 70% of these antibodies that were causing their diseases dropped. And so they were able to see this improvement in the skin disease activity. Overall, just decreased about 30% after 120 days. And their ulcerations decreased within 4 weeks. At 400 plus days, so over a year, everyone achieved significant improvement. I want to point out, though, that they didn't talk about remission and drug-free in this one. So I don't know what the difference is between the lupus patients that had such success and the scleroderma patients that didn't quite achieve remission. There was also one patient that their levels kept going back up again, so they didn't fully respond as well. So I don't know why. I don't know if there was something else, a comorbidity or a multi-diagnosis that may have impacted that. I'm not sure. They didn't go over that, but it would be interesting to note. So wrapping it up, it's just really good to know that all of this type of research, it's early, but it's happening and it's stretching out to many diseases. And just curious, what are your thoughts about this exciting new era of treatment? So we're really starting to think about this word remission. It's just amazing. So there's my report, and more coming here from EULAR 2024.
All right. Next up, let's turn it over to Deb Constein. As mentioned, Deb is one of the co-founders and co-creators of this Go With Us to Conferences program. She's a person living with rheumatoid arthritis, a retired dietitian, and a long-term volunteer with AiArthritis. So let's turn it over to Deb to talk about patient-tailored pain management.
Hi everybody, Deb Constein here, part of our core team that is attending EULAR 2024. I'm in Madison, Wisconsin, longtime volunteer of AiArthritis, and I have rheumatoid arthritis for the last 43 years, diagnosed at 13. The session I dug into today, and the reason I'm looking down is I have lots of notes in front of me, so just so you know why I'm not peeking up all the time. The session I chose was patient-tailored pain management in RMDs. RMDs are rheumatological musculoskeletal diseases, are rheumatology type diseases. And the professor that did this session was Professor Neil Basu, B-A-S-U, if I'm pronouncing that incorrectly. He's the professor of musculoskeletal disease in the University of Glasgow. And one thing that he did focus on was he doesn't blame patients for their number one priority being pain. So it was ranked pain, fatigue, valued activities, low mood, mobility, activities of daily living, and then visible joint damage. And clearly I have visible joint damage. And this was consistent across any rheumatological disease. And like psoriatic arthritis, lupus, all of them are included. He did talk about the impacts of all aspects of patient life, being functional activities, social consequences, the economic burden, and emotional well-being. So those are all the things that impact patients on a daily basis. And as we've all seen that, they call it the visual VAS. It is the 1 through 10 pain number system, and it's got like from 0 pain, and you've got a smiley face, and at 10, they have tears and crying and things like that. He said that is not the way we should be looking at pain at this point. We should be looking at it as an entire multi-dimensional disease and problem. And he talked about mapping out the different areas of the brain that are affected by pain as well. He delved deep into 3 mechanism descriptors of pain. The number 1 was nociceptive. Now, that is pain that arises from actual damage or something that causes tissue issues. And it is like an example of that would be inflammation in the joint or a broken bone for that matter. The second one was neuropathic. That is pain that is caused by the somatico-sensory nervous system. And I know I said that kind of butchered a bit, but what that is actually talking about is part of our sensory system that causes perception of touch, pressure, pain, temperature, things like that. So you understand what that is talking about. And that, an example of that would be like vasculitis. It's a neuropathic pain disorder. RA would be a nociceptive, so that number 1, that was an example of that as well. So that inflammation in the joint. And then the third piece, which he spent a lot of time on, was the nociplastic. And that is pain that happens from an altered, there's no clear evidence of there actually is an issue on I could say that I have a nociplastic pain sensation right here, but you can see that there's nothing there. There's no bruise. There's no evidence of a trauma or something like that. And things that they threw into this category was fibromyalgia as well as hypermobility, things like that. There's no clear evidence. And when they talked about what to do about this third area, which is the nociplastic pain, they recommended going to the EULAR recommendations, and you do a lot of education and exercise, those pieces that they thought that it tended to have a really good influence on people's pain in their body. And they also talked about the importance to treat the symptoms that are related to pain. So the fatigue, the anxiety, the depression, all of those things too. They talked about those can be equally as important as the pain that you're feeling. And they said when the exercise and education, when that is not enough, that you need to actually start looking at treating all of the things that are happening alongside of the pain. For some people, they can do it in a pharmacological way. If you're having sleep disturbances or anxiety, there's medications you can take. But they talked about the non-pharmacological management and looking at basically a constant behavioral therapy. So people talking to you, and that can be even over the phone, talking to a counselor, but that being all the time, as well as exercise therapy. That can actually be also done, as well as visual care is what they interpreted it into being more the educational that happens. And let's see, so a couple other things that I wanted to quickly talk about was they actually talked about the functional MRI brain imaging. So it can actually look at the oxygenated and deoxygenated hemoglobin, so the blood in your brain, and measure it as far as the activity goes and what's happening. And they're actually experimenting. Nothing is out there right now, but they're really doing some research into the functional brain imaging and looking at very specific of the brain and looking at that. They think that certain areas of the brain are talking to each other, and they're looking at the focus on that. So there was something called at the very end, it was called the TMS. It's a magnetic image, like a magnetic treatment. So something like a tool was put on the brain, and it is called transcranial modulation. And it's using magnets and trying to target certain parts of the brain to use a significant magnetic impulse to that specific part of your brain. And they're seeing that is having really good observation on the outcome of pain. Really interesting study. And there's more to come because they say that this is an ongoing thing and we need to make sure we're really driving it because it's the number one priority for patients, as most of us understand that for sure. So stay tuned, more to come.
Okay. That was awesome, right? Next up, we have Becky or Rebecca. We've been calling her Becky. So Rebecca Posey. And Rebecca is a healthcare professional, also a person living with Sjogren's disease. And this was her first time going with us. So woohoo, way to go, Becky. And she is this is a highlight of her report on opioids, pain, and fatigue. So take it away.
Hi, everyone. Becky Hosey here again, reporting on some really cool things I learned. The session that I watched was on fatigue, pain, and opioids. And actually, I'm going to break it up into 2 videos because all the information is so important, but I don't want to overwhelm you just in one long one. So I'll either record another video today or tomorrow. Really, as soon as I saw this title of the session, I knew I had to watch it. So pain and fatigue are seriously underappreciated in our patient population. And I also have an interest because I have over 10 years of clinical experience working in interventional pain medicine. So I have a bit of knowledge on this as well. The first presenter was so fascinating. She's a rheumatologist, and she started the talk by saying how many times her patients have reported to her that the fatigue and pain are worse than, say, like joint swelling or other symptoms. And she also noted how these needs are largely unmet in our patient population. A study in the US on RA noted that the most impactful symptoms were fatigue at 82% and pain at 76%. And sadly, in this study, only 26% of these patients were actually satisfied with their RA treatment. Multiple studies suggest that fatigue is actually the number 1 and pain number 2 most disabling symptoms, regardless of whether the condition is inflammatory or non-inflammatory. So that was quite interesting. The presenter went on to explain why fatigue and pain are so underappreciated. And really, it's that providers they can't see fatigue or pain, right? So they can see like joint deformities and they can see swollen fingers and toes and everything, but they can't see fatigue or pain. And she also noted she thinks there's a lot of underreporting by patients. So patients are not telling their providers about these symptoms, either because they don't think that the provider will understand, or maybe they just think, oh, it's part of this disease, or they have difficulty explaining the symptoms. Another issue that she discussed was that there's no really clear consensus of a definition of fatigue in medicine. It's really subjective. And it's really complicated, and it has various subtypes. And she talked about 2 main categories, physical fatigue and psychological fatigue, right? So we know the physical fatigue, this low energy, this muscle weakness, which she described as jelly legs, and the psychological fatigue, the brain fog, the cognitive things, the weariness. And of course, these types can occur together. They can occur in combination at the same time, or come back, leave, return another day, all types of things. Interestingly, the idea of better controlling the disease and the fatigue will get better has actually not been shown in clinical studies. Multiple studies show the opposite. So one in particular was a presentation that showed over 60% of patients with RA, psoriatic arthritis, and spondyloarthritis who reported fatigue even though they had really low disease activity. So their disease was really well controlled. They still reported fatigue. So switching gears to pain, there are accepted definitions of pain, but it's certainly not uncomplicated. But pain is really an unpleasant sensory and emotional experience. And this is a personalized experience, right? It's influenced by our biology, our psychology, social factors, things that have happened to us. And studies show that pain doesn't always equal inflammation. And studies with patients with RMDs who complain of pain, even when in remission, show that they still have residual pain, even though the inflammation is low and there's optimal treatment. One presenter said that while medicine has done a really good job of blocking pathways for inflammation, coming up with medications for these, there really has been a poor outcome for studying and treating pain. The 3 main pain categories: nociceptive pain, which arises from actual or threatened tissue damage. So these are of non-nerve tissues, and the activation of nociceptors. And one presenter she said, this is pain as it should be, an alarm telling you there's something wrong. And examples of this are tissue damage, joint inflammation. Neuropathic pain arises due to nerves being affected. And a lot of times, and not all the time, but it can follow a dermatomal pattern, which is just a fancy term for meaning like how does the nerve actually distribute? So where do you feel it? So for instance, you could have a nerve issue in your back and not have any back pain, but you could have, a numb foot. So, and, a lot of times this type of pain responds pretty well to like locally targeted treatments like nerve blocks and such like that. Nociplastic pain arises from altered nociception, but without clear evidence of actual or threatened tissue damage. So like more ambiguous. One presenter called it a volume control problem or amplification issue. And it's usually a global problem, which means that it's like widespread. And one presenter noted it's not just affecting pain, but also sensitivity to light, to hearing, right? I'm sure a lot of us have that as well. So examples of this are migraine headaches, fibromyalgia. Pain reported by patients with rheumatic disease is also often in combination. So not just one type of pain, right? So we get multiple and they're combined and they evolve over time. And there was a new study which was just published earlier this year, which was so really interesting, that looked at patients with RA who had low inflammation. It looked like their disease status was pretty stable, like well controlled. And they said, let's look at their joint fluid, right? Let's pull out fluid from their joint and just look at it. So they actually found a certain gene module, which had, 800 different combinations. And they said that was pretty consistent in all the subjects. And they took these cells and put them in culture in a lab, and the cells actually grew new nerve endings. So this was so interesting. And again, that's really all the information I have on it, because that's all really the presenter noted. But something I want to mention, because I think we'll be hearing about that in the future, so at different conferences. This same presenter also noted that studies show JAK inhibitors tend to improve pain better than some of the other biologics like TNFs. And she said again that traditional lab tests or even assessment tools like looking at swollen joints may not be reflective of the amount of pain a person is experiencing. A term, concomitant fibromyalgia, was mentioned, and this basically means that there's a significant amount of fibromyalgia that occurs in RMD patients, particularly inflammatory rheumatic diseases. And studies show that this happens about 20% of the time, and really like the general public about 2%. So something to really think about. One presenter talked about primary versus secondary fibromyalgia. And this basically has to do with which nerve pathways are affected. And she didn't say the symptoms are different in any one or worse in any one type, but she did say that if the provider can figure out which pathway is the culprit, there are different medications which could be more effective for one than the other. So that was pretty cool. There is a high rate of being diagnosed with fibromyalgia in the first 12 months of being diagnosed with a newly discovered inflammatory disease. And then also traditional inflammatory markers like CRP, ESR, that didn't predict the development of fibromyalgia. Going back to pain and fatigue, it looks like the research suggests if you live in a wealthy country, you're more likely to experience pain and fatigue than those living in a lower income country. And of course, this could be due to societal pressures on the individuals, in that patients in wealthier nations tend to really have higher health expectations. So that was pretty interesting. There are steep consequences for the medical underappreciation of fatigue and pain, including the delay of diagnoses, impacts on quality of life, negative mental effects, anxiety, depression, isolation, reduced work productivity, burden on the healthcare system, society. Really, awareness needs to be raised among patients and healthcare providers, and multiple presenters said this. We have to educate both communities on this prevalence and the significance of fatigue and pain, and there needs to be an open communication between providers and patients. And really, that providers should not just be focusing on your swollen joint or traditional lab tests, but really to incorporate comprehensive tool assessments in clinical practice regarding fatigue and pain, that these are really vital components of your overall health and need to be considered. So in medicine, we call these PROMs, or patient-reported outcome measurements. So hopefully your providers are doing this with you. These factors should really lead to a tailored treatment plan, which will be different for everybody. And that plan should be made along with the patient. And some of the treatments might be medicines, but others like physiotherapy or cognitive therapies or other interventions should also be considered. So there's a lot. And that's what I wanted to share with you today. Yes, I will have another video on the remainder of that presentation, which was just so fascinating. Again, I'm so excited to share this with you. And thank you for watching. And I will see you soon. Bye-bye.
All right. And last but certainly not least, we have Layla Valente, who is our health education manager at AiArthritis. And she is a person living with lupus nephritis and Sjogren's disease. And she is going to do an overview of brain fog. Yeah, that's a big one, right? And it's exciting to know that there is research about these symptoms, and because this is a really, really big one that many of us struggle with regardless of our diagnosis. So we're going to turn it over to Layla.
Hello, everybody. This is Layla, Health Education Manager here at AiArthritis, and I am back again with my 4th debrief and super excited to let you know about what I learned today. So I am excited to talk to you about cognitive dysfunction because it is something that so many people in our community experience, and they also don't know why it happens or what to do sometimes or how even to approach it. And it can be a very frustrating thing to go through. I personally have dealt with cognitive dysfunction issues, and so I will talk a little bit about that throughout my debrief. And the patient who spoke, she everything that she said resonated with me so much that I made my husband watch part of the session because my cognitive dysfunction has been very active the past few months, and it's been a big topic in my household. So I am excited to basically talk to you about what has been said in this session. So let's dive in. I thought it would be very helpful to share the slides for this part of the debrief. So I'm going to go ahead and do that. So she talks about how her level of cognitive functioning was before she got diagnosed with her disease. She was dealing with serious and time-sensitive issues, working with CPS, like Child Protective Services, and responsibility for vulnerable children and families, need to multitask, work under pressure, ability to plan and organize, flexibility, focus and concentration, listening and observing skills, and being attentive for and adapt to threatening or escalating situations. And after, she talks about how her symptoms were all over the place. So she did a little bit of like a visual exercise of showing how all over the place our symptoms for cognitive dysfunction can be. I copied and pasted a whole blurb of what she was saying, and I just wanted to highlight a few things. This is the part that really resonated with me. And when working on my laptop, I'm very easily distracted. I'm pretty sure many people recognize that. When I was still working as a counselor, I worked on 3 or 4 different files at a time, and now I have to just take one task, and it's difficult. I end up after 30 minutes, I look at it at the bottom of my screen, and there's 12 screens open. And I started reading emails, started replying to some of them, but never finished up, and etc. And even administration, like reading, filling in forms or reading instructions or following steps in a procedure, they can really stress me out acutely to the extent that I end up in tears or with an elevated heart rate. So she talks here a little bit about the consequences of the brain fog and the things that happen. And I think really for me, the feelings of shame and failure, frustration and denial, and feeling insecure or overconfident, it's been really big for me. And I think whenever I get stressed out so easily, I get overstimulated, I have a hard time initiating tasks, and I have to really hype myself up to go ahead and start a task. And it's been really hard. And I tried to get tested for ADHD because I thought that's what it was. And as we were going through the tests, we came to the conclusion that it's all through cognitive dysfunction that all of these things are happening. So this really hits home for me. I totally understand what she's saying. And here is the biggest part. What can we do about it? What helps her? What can we try to organize our brain and help us make sure that we don't forget things? And so taking breaks is very important. Doing puzzles/memory games, plan my day and stick to it. Developing routines, work in silence, or put a special playlist together that helps you focus instead of distracts you. Being physically active helps her as well. Doing a to-do list and prioritizing, asking for help or taking a step back, being outdoors, shutting out sensory stimuli when tired, humor, and putting things into perspective. And it feels like she was talking to me during this session. So this was a really good session for me. And for the patient session, this is the rest of her take-home points. So cognitive dysfunction can show in many shapes and forms. The patient may not realize the extent or maybe overcompensating or masking symptoms. It is up to the healthcare professionals to address the topic. Try not to ask, but also look for the signs. A small problem may have huge impact. Psychoeducation, informing and educating patients can help empower them. And dealing with cognitive dysfunction is hard work, especially when already dealing with an RMD or an AI arthritis disease. And so that was the patient segment of the session. And I am going to move on to the next part of the session. And this was a very interesting diagram that the speaker showed. It's basically showing the correlations between all of these different symptoms and cognitive dysfunction and how it can affect. There's other factors like vitamin deficiencies, other diseases, but everything that's on here can contribute to cognitive dysfunction, and just trying to address all of those different things that can affect it. And so this speaker tried to accumulate all of the different studies that had to do with cognitive dysfunction in order to do an overview of recommendations and explanation and management of cognitive dysfunction. There are other things that you can check out just to double check if there's something else wrong, if these signs of cognitive dysfunction are happening. Some things to look at could be any structural brain alterations, cardiovascular, vitamin D deficiency, hypothyroidism, vitamin B12 or folate deficiency, and the different drugs that can be causing this, such as antipsychotics or anything having codeine, benzodiazepines, things like that. The speaker also says that there aren't many studies just fully done on cognitive dysfunction. Usually they're focusing on something else, and then they have cognitive dysfunction as part of their research. So there aren't many cognitive dysfunction dedicated research studies. The biggest thing that you can do to help manage cognitive dysfunction, though, is treating the underlying disease. I tend to see that whenever my infusion is due, within like maybe 3 or 4 days, is when my brain fog is at its peak. Either that or when I'm extremely stressed out and I know that I can probably be flaring. So either in a flare or right before I need my infusion is when I am usually experiencing more intense cognitive dysfunction. So making sure that you treat the underlying disease is the main thing that you can do. They also do talk about recommending to see an occupational therapy, seeing if your insurance would pay for an occupational therapy to help you with trying to cope with all of these different symptoms and how it affects your daily life, and coming up with those routines with you and coming up with mechanisms in order to remember things. That's what occupational therapists do. They help us to live our everyday life with whatever ailment we may have at that time. And the conclusion from this segment was results tentatively indicate that levels and change of cognitive dysfunction correlate with fatigue, pain, physical inactivity, psychological distress, and sleep problems, and treating those associated factors according to existing recommendations are points to consider. So if you're not sleeping well, if you have anxiety and depression, those can definitely exacerbate cognitive dysfunction, as well as fatigue and pain, and any inactivity with exercising and things like that. The last segment talks about very specific screening tools. So they bring up 3 different screening tools, which is 1, the mini mental state examination, 2, the Addenbrooke's cognitive examination number 3, and the Montreal cognitive assessment test, or the MoCA test. And with the mini mental state examination, I'm familiar with that because I used to work in senior care. So that is used a lot for seniors and for dementia testing. And so another self-report tool is mostly our questionnaires, and this one is called MASQ, MASQ, and it's the Multiple Abilities Self-Report Questionnaire. It's a 38-item measure of self-perception of cognitive difficulties, and it focuses on language, perception, verbal memory, visual memory, and attention and concentration. And so that can still be a hard test for some people to take because it is extensive. It's 38 items. And so they also did mention another one that's called the Multidimensional Inventory of Subjective Cognitive Impairment, or MISCI, MISCI. There's 10 items on there, and you basically rate them. And it has to do with clearly thinking without extra effort, mind being sharp, remembering things, concentrating, shifting back and forth between activities. That's a really big one for me. It says I have had trouble shifting back and forth between different activities that require thinking. I call it a buffer time, but usually my buffer time between switching tasks is anywhere between 10 to 20 minutes. And it can be very frustrating to have to recenter myself again. Having trouble planning out the steps of a task, that is always very hard for me as well. And trouble finding the right words or trouble expressing myself clearly. So those are like the indicators of this test on whether or not someone is experiencing mild, moderate, or extreme or severe cognitive dysfunction. Focus on the impact of the cognitive dysfunction and the management of the other variables, and not so much the actual symptoms, but helping to manage what the symptoms cause. Because unfortunately, there is not much that we can do, or that we have found that we can do to help treat cognitive dysfunction besides treating underlying conditions and learning how to cope with it. And so that was my debrief for today. I hope that you enjoyed it and that you learned something, or at least felt heard. If cognitive dysfunction is something that you might be experiencing, I know it can be very lonely and isolating, but it's good to know that they are starting to do some research in this sector. And hopefully in the next few years, we might even have a medication or something else that explains or helps with cognitive dysfunction. Thank you again for joining us this time around for our Go With Us program to EULAR 2024. Thank you so much again, and I will see you later. Bye.
Okay, well, that was a sample, just a sample of what you can learn when you go with us to conferences, going with AiArthritis, your peers, patients, to these conferences. And we have another one coming up. Every year, ACR, November, EULAR, June. So make sure you go to aiarthritis.org/conferences. There you'll be able to get a link to all of our debriefs, not just from EULAR 2024, but all of the times we've gone in the past. So there's literally hundreds of resources that you can pull from these videos, from these debriefs. Also, if you go with us to conferences, there are 2 ways that you can get involved. You can sign up for the daily debrief. So you would get links to the videos and the recordings that you had just heard or seen, depending on how you're participating today. But also you have an elevated experience. Everything we do at AiArthritis has the option of an elevated experience, which means you can get more involved in activities to improve your healthcare journey. In this case, you can sign up to be zapped into a Slack channel, and from there, you will be able to actually talk to myself and the other people who go in person and ask questions. We do behind the scenes videos, talk to researchers, talk to other nonprofits, other advocates that might be there. It's a really unique experience, and it's free. So we definitely encourage you to sign up for that. And also, while you're on the site, please consider a donation to the organization. We work hard each and every day to make sure that we're bringing the best resources, the best patient-developed resources and patient-led opportunities to use to improve your life and the lives of the millions of people around the world living with our diseases. And there you go. That is a wrap. Signing off from AiArthritis Voices 360. Have a fabulous rest of your day.